Hi everyone, my name is Sydney Salter and I am a Doctor of Nursing Practice candidate at George Mason University. I'm excited to present the Northern Virginia Collaboration for Awareness, Recovery, and Empowerment in Opioid Use Disorder. This presentation will focus on how we can enhance screening, intervention, and referral practices for adolescents and young adults with opioid use disorder. Today, we'll cover several key topics: the prevalence of opioid use disorder, or OUD, among adolescents and young adults, medication for opioid use disorder, validated screening tools, brief interventions, referral checklists, and the referral network algorithm. These components are essential for improving early identification and treatment access for young individuals struggling with OUD. OUD is characterized by a problematic pattern of opioid use leading to significant impairment or distress. It is sometimes referred to as opioid addiction, dependence, or abuse, but it is best understood as a treatable chronic disease rather than a moral failing. By shifting our perspective, we can reduce stigma and encourage earlier intervention and treatment. So why is this important? Because nearly 90% of adults with substance use disorders started using substances during adolescence. National data from SAMHSA in 2024 estimates that 712,000 people aged 12 to 25 have OUD. In Virginia alone, opioid-related emergency visits in those aged 0 to 24 account for nearly 12% of cases. These statistics highlight the urgent need for improved screening and intervention strategies. Understanding how opioids impact the brain is crucial in recognizing why OUD develops. Opioids bind to opioid receptors in the brain, blocking pain signals and triggering a surge of dopamine. This release creates intense feelings of pleasure and euphoria, which can reinforce repeated use. However, with repeated exposure, the brain adapts and changes. Natural dopamine production decreases, leading to dependence. Over time, individuals require higher doses to achieve the same effects, a process known as tolerance. When opioid use stops, the brain struggles to function normally, resulting in withdrawal symptoms such as nausea, pain, and anxiety. Long-term opioid use weakens the brain's ability to regulate mood, decision-making, and impulse control. This fuels compulsive drug-seeking behavior and makes it extremely difficult to stop using, despite the negative consequences. By recognizing these neurological effects, we can better understand the challenges of opioid dependence and emphasize the importance of early intervention and treatment. Medication for opioid use disorder, or MOUD, is the gold standard for treatment. Despite its effectiveness, less than half of those with OUD receive MOUD, and adolescent and young adults remain underserved due to a lack of provider training in screening and referrals. Expanding access to MOUD is essential in addressing this treatment gap. Now let's look at how MOUD works to help individuals recover. This diagram illustrates the function of 4 medications used in treating OUD: methadone, buprenorphine, naltrexone, and Suboxone. Each interacts with the brain's opioid receptors in different ways. Methadone, a full agonist, fully activates opioid receptors, mimicking the effects of opioids but in a controlled, long-acting manner. It helps prevent withdrawal and cravings while allowing the brain to stabilize. Buprenorphine, which is a partial agonist, partially activates opioid receptors, producing a limited opioid effect. This reduces cravings and withdrawal symptoms without creating the same level of euphoria as full opioids. Naltrexone, which is an antagonist, completely blocks opioid receptors, preventing opioids from having any effect. This medication is useful for relapse prevention, but requires full detox before initiation. Now, Suboxone, which is the most popular these days, is buprenorphine plus naloxone combination. Suboxone contains buprenorphine, the partial agonist, and naloxone, the antagonist. The naloxone component discourages misuse. If the medication is injected instead of taken sublingually, naloxone will block the opioid effects and trigger withdrawal. Suboxone is a first-line treatment for OUD and can be prescribed by providers outside of OTPs. These medications provide crucial support for individuals in recovery by stabilizing brain chemistry and reducing the risk of relapse. However, access to MOUD remains limited, making provider training and screening and referral even more crucial. Now I'll discuss the screening portion of caring for these patients. This is the screening and referral algorithm I have created and will explain step by step for your use and understanding. Screening is the first step in early intervention. The validated screening and referral algorithm ensures that we identify at-risk individuals and connect them with appropriate resources within their region. A structured approach to screening can improve provider confidence and patient outcomes. When screening for OUD, it's important to establish a comfortable and confidential setting. Use non-judgmental language and explain confidentiality upfront. Normalize the process by presenting it as a standard part of care, such as saying, we ask all of our adolescent patients these questions to support their health and well-being. Using clear, simple language and allowing them to answer naturally improves the accuracy of responses. To identify opioid use disorder early, we use this modified screening to brief intervention tool, also known as the S2BI tool. This tool is a simple, validated screening method that helps assess opioid use in adolescents and young adults. I've modified it from the original S2BI tool, which was originally created by Boston Children's Hospital with the National Institute on Drug Abuse. The key question asks, in the past year, how many times have you used fentanyl, heroin, or any prescription pain medications that were not prescribed to you? Based on the patient's response, we categorize their risk level and determine the next steps. So if they said no use, we reinforce healthy behaviors, schedule regular follow-ups, they had a negative screening. If they stated they've used once or twice in the past year, we would want to give brief advice, emphasizing the risk of opioid misuse and educating them on the dangers of addiction. If they have stated monthly use, that is a positive screening, as well as weekly use, that's a positive screening. And if this were to happen, it would require immediate intervention and refer them to treatment services. I previously explained some of this in the last slide. However, it just reinforces the no use, the once or twice, and immediate concerns, as well as the positive screening if the S2BI response is monthly or weekly or more. If it is positive, we want to provide motivational interviewing and harm reduction, and then we want to utilize the OUD treatment referral checklist based on the American Society of Addiction Medicine's recommendations. And then finally, we want to refer to the appropriate treatment facility based on the results from that referral checklist. Now I'll discuss the brief intervention components of caring for these patients, which includes the brief advice, the education, motivational interviewing, and harm reduction. Many young people don't fully understand the dangers of opioid use. Opioids impair memory, increasing risky decision-making, worsen mental health, raise addiction risks, and strain relationships. Communicating these risks in a way that resonates with adolescents is crucial in prevention efforts. Utilizing person-first language is important because it gives the patient more respect, it reduces stigma, and it treats the person as a whole rather than just a diagnosis or a disease or a problem. So for example, instead of saying addict, addiction, or dirty, we should use a person with substance use disorder. Instead of former addict or getting clean, we can say a person in recovery. Instead of clean or sober, we could say substance free. Instead of saying treatment is the goal, we can say treatment is one path to recovery. Opioid replacement or opioid management can instead be discussed as medication-assisted treatment. And instead of saying relapse, we can say recurrence or return to substance abuse. Motivational interviewing is a collaborative, patient-centered approach that encourages individuals to explore their own motivations for change. So this would be used when a patient screens positive from the S2BI tool. Key strategies include open-ended questions, affirmations, reflections, and summaries, commonly referred to as ORs. Rolling with resistance and promoting autonomy helps patients feel empowered rather than pressured. For open-ended questions, we should ask questions that can't be answered with yes or no. For affirmations, we should recognize and encourage a person's strengths. With reflections, we need to respond in a way that makes it obvious that you've been listening carefully. The other person can then make corrections if they did not express themselves fully. This also allows the listener to express empathy, the ability to see the world through another's eyes and share it in their feelings and experiences. This can make the other person feel heard and understood. Some examples of reflections include, "That must be difficult. I hear that you're upset. It sounds like," "What I hear you saying is," some examples of summaries allow the listener to recap what has been discussed. The person can highlight the other person's strengths and reasons for change. Harm reduction is a transformative approach that prioritizes safety and well-being. This includes overdose education, naloxone distribution, access to fentanyl test strips, syringe exchange programs, and peer recovery support services. The goal is to reduce harm while keeping individuals engaged in care. Next, I will be discussing more on the referral network algorithm that I've created. Implementing a referral network algorithm tailored to the Northern Virginia region improves patient outcomes and provider efficiency by ensuring a structured and standardized approach to opioid use disorder treatment referrals. Let's go over the key benefits. Those include standardized referrals, which ensures consistency in patient care, early intervention, which helps identify and connect AYAs to MOUDs sooner, provider coordination, which helps streamline communication and workflow, increase provider confidence, which enhances skills in managing OUD, expanded access by connecting patients to multidisciplinary care, system improvements, which supports system quality improvement initiatives, and stronger community collaboration, which helps strengthen partnerships across sectors. So let's do a little recap. I've already discussed the pink box about screening the patient first using the modified S2BI tool. If there are immediate concerns, which shows in the purple box, you would need to contact emergency services or call 911 or send them to the nearest emergency room. If they screen positive, we've discussed the motivational interviewing, harm reduction, and education. And if they screen negative in the green box, we would just reinforce healthy behaviors and follow up accordingly. So, following along in the blue box, if they screen positive, we then want to utilize the OUD treatment referral checklist to determine the treatment services that the patient would need. This will help us decide the appropriate level of care based on withdrawal symptoms, substance or opioid use severity, mental health, relapse risk, and social environment. As I mentioned, but to reiterate, this referral checklist helps determine the appropriate level of care based on factors like withdrawal symptoms, severity of use, mental health status, risk of relapse, and social environment. This systematic approach ensures that we match patients with the best suited treatment option. So in this slide, we have the first two steps. The first step is to assess withdrawal symptoms, and you would go through and see how the patient is doing and whether or not they're having no withdrawal, mild withdrawal, moderate, or severe. And there are examples in parentheses of what that may look like. The second step is to assess the substance use severity. So, is it mild use, no major life disruptions, moderate use, struggling with work or relationships, heavy use, multiple failed quick attempts, significant life problems, or severe daily use, unable to function with daily life. And with each of these steps, there's an arrow pointing to the best treatment option for them. However, we will go through each step to overall look at where they score in each step. So going into steps 3 and 4, step 3 is assessing the mental health needs. Do they have co-occurring mental health concerns, such as mild anxiety or depression, moderate mental health struggles, or severe mental health struggles? And once again, the examples are in the parentheses right there. And then step 4 is assessing their risk of relapse. How likely are they to relapse? And once again, the descriptions are listed below that, such as a low risk, a moderate risk, high risk, or severe risk. And then we will go through step 5, and then step 6 is the final one to determine what level of care they need. Step 5 is to assess the home and social support. So it's important to find out from the patient if they're in a stable home, if it's unstable, maybe they're homeless, maybe they don't have a good support system, any of those situations. And then we have step 6, determine the most appropriate level of care. Based on the answers above, you'll choose the best treatment option. So, if they are majority in the first box of each step, it would be outpatient. If they are majority for intensive outpatient, it would be that, partial hospitalization, or residential inpatient treatment, or detox. And examples are listed next to it as well. And then we are also going to run through a patient example. So now let's go through a case study of a practice patient scenario. So here we have a 17-year-old female. She's a high school senior, active in dance and theater. She plans to go to college next year. Recently, she fell into a new group of friends who use opioids recreationally, mainly pills like Percocet and oxycodone, or really whatever they can get their hands on out there. They are obtained from social media, DMing people, or at parties. She has a medical history of anxiety and panic attacks, but she's never received formal treatment. She also has not had prior substance use history before this year. Her current symptoms include she's been taking Adderall to study for exams, but was introduced to opioids by friends. So now she uses opioids 3 to 4 times per week, sometimes combining them with alcohol or weed. She reports trouble sleeping, mood swings, and increased anxiety when she doesn't use. For social history, she lives with her parents who are unaware of her using opioids, but she maintains a good GPA. However, she is skipping classes more often, losing interest in her extracurriculars, and her friends are pressuring her to take pills at parties, saying that they help her relax and have more fun. Her screening result from this was a positive S2BI, reporting using opioids 3 to 4 times per week. Some barriers to treatment include fear of her parents finding out and the belief that she can stop anytime, as well as some social pressure. She is on her parents' PPO plan until age 26, so she has private insurance. So let's go ahead and use the OUD screening and referral algorithm. The first step is using the pink box, which is screening the patient utilizing the modified S2BI tool. This patient stated that she was using opioids 3 to 4 times a week in the past year, so she is under the weekly use category and it is a positive screening. Now that we've established that she had a positive screening, it's moved on to the blue box, so we would provide motivational interviewing and harm reduction. After that, we would be utilizing the OUD treatment referral checklist to determine the treatment services. Now we have the referral checklist to determine the appropriate level of care. So we're first going to assess her withdrawal symptoms, and they were trouble sleeping, mood swings, and increased anxiety when she was not taking opioids. So this could be under mild or moderate withdrawal. It is a little subjective. However, she's not in severe withdrawal, which would be seizures, hallucinations, and confusion. The next step would be assessing substance use severity. She is in moderate use because she is struggling a little bit in school and with her relationships. So with this, it would be suggested to have outpatient or intensive outpatient treatment. This patient's past medical history included anxiety and some panic attacks. So for assessing her mental health needs, she does have mild anxiety or depression. And then in step 4, we want to assess the risk of relapse. She is under a moderate risk, occasional relapses, but some control. And this is mostly because she is using 3 to 4 times per week, and she has that peer pressure of continuing to use. Now we're on step 5, which is assessing home and social support. She does have some instability and she's exposed to triggers with her friends and with school. And she may or may not have limited support, mostly because her parents are unaware at the moment. Now, in step 6, we want to determine the most appropriate level of care. The majority of the responses that we have checked were for intensive outpatient care. If there was a step that she was needing residential treatment or detox, we would definitely want to resort to that, as we want her to have the best help possible. However, for her, she's experiencing moderate substance use and some life struggles, so intensive outpatient or level 2.1 is appropriate for her. So we've determined that this patient would be moderate OUD, needing level 2.1 care. To support effective referrals, I provided a list of treatment facilities that offer evidence-based care. This list of local facilities is divided by different counties. We have Fairfax County, Loudoun County, and Prince William County. I have went through and run patient tests and patient referrals through each facility to determine the appropriate contact information and level of referrals. Feel free to click the link on this slide to be able to see this entire list, and as well as in this Google Classroom at the bottom in additional resources, you can see the list as well. This is an example showing an example of referral to treatment location. This is George Mason University's Mason & Partner MOUD clinic. So I've included the address, the website, their preferred referral method, which is phone call or QR code. I've also included the insurances they accept, the ages that they treat, if they treat pregnant patients, and then of course the level of care that they provide. So this specific clinic treats levels 1.0 and 2.1, which is outpatient and intensive outpatient. And for each facility on this list, I have listed out the details of their contact information and important requirements. Thank you all so much for completing this training. Before we wrap up, I wanted to post this post-training survey for a chance to win an Amazon e-gift card. There is also a link for an opportunity to sign up for one-on-one training sessions, and we can run through other patient scenarios. And there is as well as additional resources at the bottom of the Google Classroom, and there is an open forum that we can have for questions and discussions. Thank you.